Welcome to Public Health on Call, a new podcast from the Johns Hopkins Bloomberg School of Public Health. Our focus is the novel coronavirus. I'm Josh Sharfstein, a faculty member at Johns Hopkins and also a former secretary of Maryland's Health Department. Our goal with this podcast is to bring evidence and experts to help you understand today's news about the novel coronavirus and what it means for tomorrow. If you have questions, you can email them to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, I speak with Dr. Alex Biloux, the Assistant Secretary for the Office of Public Health in the Louisiana Department of Health. We speak about the rise in cases across the South and the West, and how Louisiana's early exposure to the virus has helped prepare for this current surge. Let's listen. Dr. Biloux, thank you so much for joining me. We're at a point right now where to your east, Florida is seeing a huge surge of cases. To your west, you have Texas. To your north, Arkansas. How are things going in Louisiana?
Yeah, well, even at home now, we're seeing a rise in cases, and we're seeing even in our hospitals, more people being admitted with COVID. And in our surveillance system, we're seeing more COVID-like illness in our emergency departments. So what we're seeing around us is also being born here.
Where are you in terms of your curve compared to some of these other places? Like we're hearing about Houston running out of intensive care unit beds. Is that the situation in New Orleans?
So not yet. And I think, given how much we've been able to build in monitoring infrastructure since the early days when we were really one of the first 3 or 4 hotspots in the country, I think we've got a pretty good sense of our capacities. And while we're seeing increased admissions, we're seeing impacts on decreased utilization or ICU capacity. We're not yet at a crisis level. What we're concerned about is we know from experience, from real experience, last time, just how rapidly things can escalate and grow. And we don't want to go back to that situation. We don't have to.
Yeah, so you're making a good point. Unlike those other states, Texas, Florida, Arkansas, Louisiana saw some surges very early on. New Orleans was a huge hotspot and you were worried about your hospital capacity. What did you do at that point? Because you subsequently had just a huge fall in cases.
Yeah, well, I think, we in our first 13 days had the highest or the most rapid rise really in the world at that point. And so I think we tried to get out to the public as quickly as possible, convey that message, start with enforcing or putting in place some distancing and measures and trying to reduce gatherings around schools. But within 2 weeks said, nope, we need to move to stay at home, and really conveyed a clear message based on data about staying at home. And our curve shows you that, Louisiana got that message loud and clear. People stayed at home, mobility dropped, and our cases dropped. And it was still a slower drop than we would like. But when you now look in retrospect at our curve compared to others, we are really surprised at how quickly we were able to get our cases down. And really the decline, the peak of our cases came 2 weeks after our stay-at-home order, almost to the day. So clearly the people of Louisiana acted to turn things around.
And what else did you do at the health department besides, give that advice?
Well, I think the big thing that we've tried to do since the beginning and we continue to iterate on is just sharing a lot of actionable data with the public. We wanted them to see what we were seeing. We wanted them to be able to follow along. We have had a dashboard for quite some time before I think many states had theirs fully up to date. And we continue to try to think of new ways to visualize down to the neighborhood level what's going on in your community. So that people really can understand that we're not just sort of, raising the alarm by ourselves. We can show them the data and they can see, what's going on. And I think we've had really clear leadership from the governor. I think he's been very consistent in what we know, what we don't know, and in emphasizing that we're not going to get out of this through enforcement, that this has to be acting as good neighbors, taking it upon ourselves to do the things we can, like staying at home, like taking care of our older neighbors and not asking them to go out. And now I think the challenge is having that message around masking, which is particularly problematic.
So tell me about the masking situation in Louisiana.
Well, I don't think it's unique to Louisiana. I think that unfortunately mask wearing has become somehow a politicized issue. I think, what makes it even more challenging for those of us in public health and academic, public health backgrounds or a medical background in my case, is that, what we had early on is a debate about the proper use of PPE. Should surgical masks be used by the general public when we have, inadequate PPE supplies for people in healthcare? Is now being interpreted by the public as, well, you used to think masks were a bad idea. Now you think masks are a good idea. You can't make up your mind. The WHO is at odds with the CDC. And frankly, it's now cutting to political parties where it's almost a sign of your political affiliation when you wear a mask or don't. And that's just a really unfortunate distraction from what is a fundamentally simple message about, keeping viral shedding around your face and not letting it be in public as being one of the most important things we could do to just generally make it safer for us to re-engage our economy, re-engage as we all want to.
How is contact tracing going at this point?
So it's a mixed bag. We followed Massachusetts' example and quickly stood up a system based on call centers and with a shared IT backbone. And that's been really successful. We've had a challenge with having adequate contact information for individuals. It's about 30% of individuals we don't have adequate contact information for. But of those we do, we're reaching, 97% plus. And that's really heartening. Our infrastructure is there. We have the numbers to do it. What's disheartening is the actual engagement with contact tracing is not where we need it to be for it to be effective. Around 60% of the people we're reaching are telling us they have no contacts. We're happy that only 4% of people are actually not willing to speak with us, but that's still 4% of people who, we need their participation. And I should say, and I know you know this and your listeners know this, we're not just trying to gather information from them. We're also giving them resources and support, not only to understand how they can reduce the risk of their household, but we've been, connecting people with resources, cleaning supplies, masks, but also, help with groceries, food, housing if needed. So we're really trying to convey that message to the public. We're just not getting the kind of actionable data that we need to really be at the point of the spear. We're getting a lot more information by report sometimes than by contact tracing.
So you have a very strong dashboard. You're able to tell people about where things stand in Louisiana. You've had this challenging messaging situation about masks. You're working to get contact tracing to be more effective. But you're seeing these cases increase, just like your neighboring states. Why are they going up, do you think?
We all expected that there would be more cases as we moved into phases. We're now in Louisiana's phase 2. And phase 2 involves, a lot of things that cater to sort of more recreational engagement. So we've got bars that are open. We knew from an international standpoint that those might be problematic. We've got places of amusement like bowling alleys and other places that are open. And my concern is that what we're seeing is a specific rise in 18 to 29-year-olds and under 18-year-olds. Interestingly, if there's any sort of silver lining for the moment, our case identification in 60-plus year olds has stayed stable, has not really increased. And that's as we're surging, comprehensive testing in nursing homes and adult residential care settings. So we're doing more testing there, finding more asymptomatic cases, and yet it's still not where we're seeing the rise. Where we're seeing the rise are in young adults who may be in the workforce, may be essential workers, but we also have concerns that there are people who the message of personal safety is not resonating, and who are engaging in more of these maybe amusement type activities that we've rolled out in phase 2.
I just saw that the Texas governor has closed the bars in Texas. Do you think that is a potential tool for other states, including Louisiana?
Well, I think, from an Office of Public Health's perspective, we are looking at all of the data, all the clusters to find where we having problems. I think we're seeing, certainly we had some significant outbreaks related to bars, especially around college campuses, which is very concerning. I know the governor's raised some specific concerns about. We're also seeing, gatherings in general, weddings, funerals, even church services where, people are below our limit threshold. And yet because of social distancing being difficult to implement or maintain or masks not being worn, we're just getting lots of case clusters there where people are coming together in in gatherings that are about coming together. And I think that's one of the hardest things for people, is those kinds of environments. And that's what happens at a bar too, right? At the beginning of the day, beginning of the bar opening, people are fine sitting and staying stable. But the point is often to come together and to speak with each other and drink without masks on. And we're social beings. At the end of the day, or at the end of these functions, we want to be near each other, and we take risks. And not surprisingly, then we see that creates new cases and clusters.
So we're sort of in a new stage of this, where it's creeping up. You're now in the creeping up stage where the numbers are getting bigger and bigger every day. And you're looking to your neighbors about, what could be in your not so distant future. How do you penetrate into the, 18 to 29-year-olds? What's your thinking about how to turn this around faster? Or do you think it's got to be calamity before people get really serious, like happened the first time in Louisiana?
Well, I'm hoping it's not calamity that we have to go with. We've talked with college age students. Just our communications teams have reached out to try to understand what they're thinking, where they get their sources of information. I think, traditionally we've been focused, like a lot of places, on, press conferences and traditional media. I think we need a, better social media game. But I also think, it's not naivete or ignorance. I think that, what we're hear from 18 to 21-year-olds is, well, look, we think that if the government is saying that something can be open, that it's essentially safe. So why is it a problem that I go there? You're telling me this is okay to be open, but then you're telling me don't go there. That's a mixed message. And I think that's a pretty astute observation. I think we need to think about the data that we have now as we've been rolling out, and not just Louisiana, but other states, as we've been rolling out access to different sectors. And like places like South Korea and the United Kingdom, who have rolled back specific relaxed restrictions, I think we need to do the same. We need to be data-driven with contact tracing and say, we thought this was going to be okay. It's not right yet. And we need to roll that back. And I think bars are on the table for that.
How about the intense disparities that have existed with the COVID-19? I know in New Orleans, there have been some particular disparities seen. Is that story been changing with this newer rise?
So it actually has, which is heartening. Again, I'm not happy that anybody's getting COVID, much less dying of COVID. I think early on, what we were learning from members of the African American community was that there was a narrative that was running through their communities about lack of risk for COVID. I think we were one of the early states in showing our death data, even when it was painful for us to do that because we couldn't explain enough of what we were seeing, but we thought it was urgent enough to share it, to sort of put that out there when we couldn't explain everything.
Showing the disparities.
Showing the disparity. I mean, we had, initially 2/3 of deaths in our state were from the African American community, whereas the African American community makes up less than 1/3 of the population. So really double the level of mortality as the white community. And now we're getting closer to parity. It's still a disparity. We have 53% of the African American, or 53% of deaths are in the African American community, 45% within the Caucasians. And so that disparity still exists, but we've really started to narrow. And I think partially because we've worked through a health equity task force, but also through just sharing that data and raising alarm bells about long-standing health disparities and the impacts of racism in a state like Louisiana, to mobilize that community to take more of the health risk in their hands. And we're seeing, higher levels of masking. We're seeing, frankly, a difference in attitudes amongst African-American churches, or predominantly African-American churches, and white churches in masking, adhering to not singing during services and things like that, which tells me that message and that data was really important for people to understand the impact it was having on their community. Still a long way to go.
Yeah. What's on your long way to go agenda for that?
Well, I think the tip of the iceberg is really COVID-related deaths. We know that it has to do with, not only access to healthcare, but need for healthcare, meaning disparities in overall health status in the African American community. That's always been the work of the Office of Public Health. We've had health equity activities going on across our department and in everything we do. But I think we need to go even a further step and look upstream and say, we've got this opportunity. We've got a shining light on, especially now with the recent protests and I think a lens on the deadliness of racism. to say, what are we going to do that's actually going to solve this problem down the road, not just for COVID? What are we going to do to address the fact that families are living in poverty, that they are over incarcerated, that they don't have access to educations that allow individuals to actually make the most of their opportunities, and then have all these beneficial health outcomes that are enjoyed by the white population.
Got it. So it sounds like your length of your workday may be going back up again as the curve goes up. Is that what you perceive? More intense pressure, more worry for you? And just last question really is just like, what is this personally like for you as you're leading this department at this point?
So I think it's been challenging. I think we are very anxious about the rise that we're seeing. I think a lot of us feel like, here we go again. I think, when we look across people in my same position across the country, I think we're seeing higher rates of turnover, because I think that in general, what I hear from my team, and I'm sure others are feeling, is this concern that we've been trying to give the best public health guidance and evidence. And there was a period where that seemed to be really well appreciated. There was a poll done early in Louisiana's epidemic, maybe a month in, that showed that actually the Department of Health had the highest level of trust in the state, higher than personal physicians. And I think that was because of clear messaging, clear data, and really trying to answer the many, many, many questions people had. What we're seeing is that same tactic, which hasn't changed on our side, is now no longer having the same resonance. And we're seeing things go in the bad direction without really understanding how we can effectively turn that around if people don't want to hear that message. And I think that leads to some feelings of
little burnout, maybe.
Well, a little bit of burnout. Yeah, I think that we're certainly seeing the teams concerned. Demoralization, I think, is the word I'm looking for. I think we're seeing people be demoralized because they're putting in tons of effort, and we can't go out there and make people stay at home. We can't make people wear their masks.
Right.
We're just trying to inform them about the best health decisions they can make.
Well, I think, public health always has this challenge, and you're always trying to find, new ways to connect to people and new ways to inspire action that people can take to help themselves and others. And Louisiana has been very successful at this point. You really responded incredibly well to a very urgent situation. But that doesn't necessarily mean that what worked the last time is going to work this time. So much has changed. And so you're going to have to be resourceful again. But I know kind of public health leader you are, and I really wish you and your team the very best as you're confronting this challenge.
Well, thanks, Josh.
Thank you for listening to Public Health on Call, a new podcast from the Johns Hopkins Bloomberg School of Public Health. Please send questions to be covered in future podcasts to publichealthquestion@jhu.edu. This podcast is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Lamare Morales. Audio production by Niall Owen McCusker and Spencer Greer, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.